Hello, I'm truly humbled to have Hiro Yamamoto next to me.
Thank you.
You are like a god, okay? You walk on water. You're the father, you're the innovator of deep endoscopy and ESD. So our resection techniques, they are all your genius. And so it's really a privilege. And my very minor contribution has been to harness the power of water. It's always saline, by the way, so we never use water. But you know, the ocean is filled with saline, and we still call it water, right? I mean, you don't say, I'm going to go jump in the saline. You say, I'm going to jump in the water.
Yes.
So it's underwater, but it's always saline because you need the conductivity. So I haven't started. What I love about this course is I've got some time, 30 minutes, they tell me, and that should be sufficient. And this could be just like another day in my practice, because I do several of these every day. We have a large referral volume, and as much as I love ESD, and I do use ESD in the rectum and in the upper GI tract, but in the colon, it's just too time-consuming. So I do underwater EMR. There are some exceptions, and that's if we're dealing with cancer. You know, with superficial cancer, then I want to get en bloc. All right, so I'll stop here. I got Shinichi, right? Yes. Shinichi, correct. I've got your name correct? No, Takashi. Takashi. See? He said yes. Takashi. I'm so sorry. All right, so let's get started now. And what I'd like to show you is we have the gas off. All right, so please turn the gas off. I do what's called water exchange colonoscopy. I start just with water, saline. So I'm going to insert now. And I've got my water pedal here. And I use an adult colonoscope. And there's a reason for that. By the way, I should show you how I do this. I like to have the scope straight like this. And if you can give me a small towel or something so that I can hold the shaft, the best is a little towel here. So I keep my hand close to the anus so I can torque as I'm going in. Because the underwater journey through the GI tract is a constant torquing and looking for the lumen. And I keep my foot on the water pedal pretty much the entire time. So I'm using the water, and I'm going to say water, but it's always saline, just so you know. But I'm using the water to distend. So this is called the flushing. When I do ESD, the injection is through the knife, and that is, we call it injection, right? But the flushing is through the water jet channel, so I'm using the water jet channel. So now I'm distending with the water. I don't hear the water. Is it going in?
Don't use a cap.
There's a cap. You don't see the cap because we're underwater.
Okay. Good.
So what does underwater give us in terms of the diagnostic for the intubation? It gives us somehow the, is it working? The water jet channel stopped working.
Could you step again?
Yeah.
Step again.
Now? Okay, now it's working? Okay, so I want you to see this technique is just sort of a very, now it stopped again. So you need to have a fairly powerful water jet because what it's doing, that's how I see the lumen. Otherwise, if you can't see the lumen or if there's a lot of contamination, well then I'll give little puffs of gas. But I try to avoid the gas because then I have to deal with the gas-water interface, that they have different indices of refraction, and that's confusing.
I think you have to step again.
Now I got it.
It automatically stops.
It automatically stops. Okay.
Yeah, I don't know why, but the Japanese
can we
machine.
make it so that it stays on? So I don't have to keep pressing down. So what I'm doing here, so through the sigmoid colon, I'm just sort of advancing through, and there's going to be some looping here. I see. This is a little bit difficult with constantly having to step on the water.
Yes.
Is there not a setting where I can
no,
just have it go continuous?
It's not available.
Not available.
Manufacturers say that's for the safety.
So Takashi, I'll have you just keep stepping on the water then. So what I got to do here, because she has a lot of angulation here.
踏み続けで、だけどオートマチックに止まるから、止まったら踏み直して、常に入れっぱなし。
Yeah, so I have to find the lumen and keep stepping on the water. So my water pump at home, I can continuously, and you can see how I'm just gently pushing, right? This is called slide by. So I'm sliding by like this, just gentle. This is the haptics, the tactile. And this is what I think is going to take a long time for a robot to ever be able to reproduce, this tactile. So I'm just advancing forward, and then I know that here I've got to torque a little bit, keep giving the water, because the water is what does the distension. So the water is replacing the gas as a way of that I distend. And do you have like a little towel? Because this gauze here keeps
タオルある？
a little towel or something? Yeah. All right, so I'm just very gently advancing and sliding by. So you see, I don't see the lumen, but there we go. So you have to know just the right amount of resistance that you can push through, because we are pushing through some loops. Good. And then I have my assistant. So Takashi, can you hold the scope here for a moment? Because I'm going to, and then I actually have also, sometimes I'll have my assistant push for me. Takashi, can you do that for me? Because I've got like a turn here I've got to make. Okay, and keep pushing, please. Keep pushing and keep your foot on that pedal. So what I'm doing is called water exchange. So I'm clearing out all the debris in here so that literally you can eat a meal from the colon afterwards. It's going to be so squeaky clean. But that's really what gives us the high ADR. I think the high ADR that's been shown in multiple randomized controlled trials using the water exchange method. It's in part the fact that the lumen is sort of collapsed down and you can see behind folds, but it's also that the mucosa is really cleaned off. That's why I think especially these SSAs are so much easier to detect.
By the way, do you use near focus on purpose?
Oh yes, because underwater you need the near focus.
Oh really?
So I have the near focus on intentionally, and so that's why the near focus is my default when I'm underwater. So I'm trying to straighten, and then I might have one of the assistants give some abdominal pressure.
Okay.
I again have to push through this loop here.
The sigmoid colon?
So sigmoid colon. What an honor to have you doing the pressure for me. Okay.
My honor.
All right, so now I'm just going a little further. So this is all residual gas inside the colon, and I'm just going through, and as I push through, and as you get into the right colon, it gets dirty and dirtier, right? So that's where you really want to clean things off very, very well. So I'm sucking the whole time while Takashi is giving the water. And now I think I've got one more turn that I have to make here. So let's sort of see. What I'm doing is I'm reducing, I'm just pulling back and looking to see where the lumen is. This is where, Takashi, can you hold just for a moment, just to prevent me from kind of falling back again? One moment. All right. So here I'm hitting up against. Now, every once in a while, if you're up against a fold and you can't see where the lumen is, or you're not getting there, then I will give little puffs of gas. So I'm just slowly pulling back to get an idea where the lumen is. And if I can see it underwater, great, I can push towards it. But otherwise, he's got a lot of bubbles here. Okay, here we go. Here we go. Here we go. Okay, now we go down this way. Keep cleaning this out. There's the IC valve. You see it nicely floating towards you. And I'm going to push into the cecum now. See, it's dirty. I want to take this time. So the other thing that, just if you were to have a perforation and you have sterile saline in here, that perforation is relatively safe. Yes, you might get a little bit of, stop the irrigation. I'll take over because we're in the cecum, so now I can take over. you're going to have some pressure differential, but it's going to be very mild, and it's going to be, of course, very magnitudes different when you're using gas, where the gas just immediately escapes out. You know, it's like a balloon that pops. So the reason why I think underwater, when you perforate, why these patients often have virtually no pain afterwards, is if you avoid giving any gas. It's the gas that causes the pain. It's the same reason why I do underwater poem. You know, I think it's the gas in the mediastinum that causes the pain, whereas we're 80% water, you know? So water is sort of friendly. The body does not view water as an enemy. So we're relatively safe, but of course we don't want contaminated. Now look at this. This is the IC valve, and now when you're underwater, then the IC valve just sort of floats up towards you. And I'm using the cap to sort of very slowly and gently torque my way into the ilium. See, and it's that little tiny movements here. I'm just rotating a little bit and gently pushing in. Now, it's amazing how deep you can intubate underwater. You know, so when I do my enteroscopies, including, you know, double balloon and all, I use water always because I can get much further in. So if you're just patient and just sort of sit here and wait, sometimes it's almost like, imagine you're a boat and you're just waiting for that wave to just carry you upstream, you know? So we won't belabor this too long, but you see how beautiful you see the villi. And then, of course, you can, I didn't test all these buttons, but here's your NBI. It's just beautiful. Look at these little tiny villi. You know, this is like scuba diving. You don't need to scuba dive. You've got this like a coral reef right in front of you. And if you give the water, you can see like the movement of these villi. And it gives you an appreciation of just how magnificent the human body is, you know? So just take the time to enjoy the view. And the view is spectacular thanks to these incredible optics that we have. So now as I come out, you can see how it just all floats in front of you. So it's that anti-gravity effect that I love, that 3D effect. And look how the IC valve, it likes me. When you give gas, you push this away from you, so it can be hard to get into the terminal ileum. Here it's just floating and inviting you to come inside. So now you can really pick up small lesions that may be on the IC valve, you know. And for that matter, and I don't know, just because we have a little bit of extra time, I do always like to find the AO, and then I'll give some water to interrogate the inside of the AO. So let's see if I can do that. Should be somewhere up here. And I may or may not be able to see the AO. I don't want to spend too much time, but I have discovered many SSAs. Ah, there it is. Here it is. Look, so here's the AO, and you can sit here and just use the, see how I'm using the water to interrogate. And look at the blanching. So if there's a little too powerful suction. I put my suction always down a lot. So I'm using, if you look at the water, see how it blanches like this? It gives you feedback also about the consistency, the compliance of the tissue. You know, scar tissue reacts very different from normal tissue. So you can use the water to open up the AO and then discover, not uncommonly, that there are some hidden creatures inside, like SSAs. All right, so let's start coming back because we want to now find our lesion. So you can see there's still a lot of debris. So I'm staying underwater. So when I do the whole procedure underwater, I never give gas, or I try to avoid it unless I have to. But what's important is to do like a helical circulation like this. So I'm just going in circles like this, and there's our lesion already, right? Just floating in front of you. Now, you know, I suppose for demonstration, I could put gas in to show you, but let me tell you, if you put gas in, it's going to increase in size significantly. I'm on NBI right now, and you just see it so nicely, but I want you to appreciate how I can use the water to move it around like this. And so let's go on to the standard white light. And this is a 33? Yes. Okay, good. So I'm going to use the biggest snare there is. I wish there were bigger, but 33 is the largest captivator too from Boston Scientific. Now, admittedly, I can't see the oral end that well, right? So that's the proximal end. I'm going to try to make some dots at the margin of that, but it sort of is a little, this is on a fold, you see that, right? And so it kind of takes a dive down, and that's where sometimes I will actually inject, but if I'm injecting, it's just to raise this opposite side here so that that oral end elevates a little bit more. Okay, so I want to show you how I make my dots. So advance the snare out a little bit. So keep it, now pull it in, and you can look through the catheter, it's transparent, pull it in a little bit more, till it's just recessed inside. A little bit more, perfect Takashi, doing great. Okay, a little bit more. Okay, now it's inside. Now I can use the tip here, and I'm just going to maneuver around, and sometimes I'll have an assistant hold, but I'm holding this like here. It's a little too far out, Takashi, because we don't want to create a hole in the colon wall is very thin, so a little bit squishy.
Yeah.
Okay, good. Now let's just make our dots. See, you'll see here a nice, and then can I have the assistant here just give me water? I'll say when I need it, just because I have to step on the cautery pedal. So that's not a nice dot, really. I'd like to have it nice and round. Let's see. Okay, that's better. Just maybe spend a little bit more time. So these are the dots. Now, all you have to pay attention to is you make your dot where the mucosa is normal. So just make sure that you're outside where the mucosa is normal. Now, we're not doing ESD, so it's not like you have to have these dots so close together. I just want to have an idea where I need to give me some water again. I want to have an idea. Oh, that one didn't make a nice crisp dot. Not sure why, but
Hello, Ken.
I like it when the dots
Hello?
are really nice and round and crisp.
Hello?
Now I'm going to try to get to the back side. This gets tricky because when you make your dot here, it may actually be kind of far removed from the lesion. And I don't know that we have to spend too much time doing this. I'm just going to show you how I'm trying to move with my catheter. I'm trying to move the lesion over, maybe just enough so that I can see that transition between,
Maybe we don't have enough time.
yeah. Pardon me?
We don't have enough time for the transmission.
Okay, good. Open. I got the message. Okay, open the snare all the way.
Could you let us
So
know
what I'm doing is
the
I'm going to impact
setting?
the tip here,
Oh,
right? And I'm going to, this is like a lasso, and it will open up nice and round like this. And now I'm going to just I'm going to sit and I'm going to do what's called the water pull. So I'm aspirating now some of the water. You heard a bit about this discussion with the underwater ESD. So I'm contracting the lumen with the goal that this lesion floats up into my snare. I want to take advantage of the floating effect. That floating effect is mainly due to the submucosal fat here that allows it to float up. And see how it's already starting to get some buoyancy and float up? So, and then I use the jiggle maneuver. I love to jiggle. So I'm jiggling to let this lesion come up into the snare. And then I use a little to and fro, right? I'm kind of pushing the snare a little bit forward and back. So now you can see it's almost like a stalk, right? And I think I've got the right and the left side pretty well. And now Takashi's going to close the snare. And while he closes, I'm going to look, and let me have the water pedal. I actually give a little bit of water as he closes. And I told Takashi, I want you to just close it firmly, but don't cut through. And I'm looking for the discoloration. It'll give me information about how much of the lesion I've captured. It should turn sort of violaceous. You can see how it's becoming more engorged, right? So it's an indication that I've got most of this lesion, and there's a decent chance that I'll get this on block. But if not, it'll be attempted on block, and then I'll do a little trimming on the edge if necessary. All right, but my goal is always on block. All right, so you see how it turned color now, right? I wait for that. And actually, we're strangulating also the blood vessels, so this will also reduce the risk of bleeding. So I think it's really good right now. So now it's called the 2 Bs, Takashi. So we talked about this. The first B is bubbles, And the second B is blanching. Blanching means turning white. Okay? So we're going to wait. I'm going to step on the 10 minutes. Okay. I'm going to step on the pedal, and I'm using auto cut and using the Vial 3. It's a 1.6 effect. All right? These are settings I use at home.
So you don't use the end cut.
I don't use endocut. I use auto cut. But I get the cautery effect because I'm not cutting through right away. I'm going to wait till I see the two Bs. All right? Okay. So are we ready? We're just going to sit here and wait. And I'm going to give some water while I do this because there's a heat sink effect that you get with the water, okay? All right. So now I'm giving, and let's wait until we see some bubbles and some blanching. I think we're starting to see that. Good. You see the bubbles coming? All right, now start to cut, please. Start to cut. Good. Go ahead and cut through. There, it's through. All right, now, let me just push this over like this. Okay, so I mean, now look, we got some collateral damage. And that sometimes happens because the opposite fold. But what I'm interested in is this here, okay? So I'm going to look at this surface here. It's along the fold. And before I do anything, you know, I'm going to inspect the margins and see if I have any residual. And let's look at this side, see? Oh, it looks pretty good.
Yeah, pretty good.
Right? Looks pretty good. You see the chicken skin, right? Now look, there's no bleeding. And the reason why there's no bleeding is we compressed everything, right? We strangulated off the blood vessels. I waited and gave this. So I used auto cut, but still I was taking some time to give coagulation. I didn't step on coagulation, but you got that coagulation effect. So now that I know there's no perforation, right? And it looks like I got the margins pretty well. Now we switch the gas on. Okay, now you don't have to do that though. I mean, the only reason to do that would have been to show you how this surface area looks pretty small, right? Now we call it the footprint. Well, this footprint, it grows by, you know, it's the Viagra effect. It really expands. All right, now if you want to coagulate the margins, I do it with SSAs. I don't do it routinely, but the same technique. So Takashi, I want you to push the snare out and then pull it back in, recessed in. So it's right at the tip. Pull back, pull back, pull back, pull back a little bit more. It's a little bit of gunk on the end there, but you can use this to just go around the margins like this if you want. For that, you want to use coagulation current, right? The force coag. So if you want to do that, you can do it. I mean, this is a Michael Burke thing.
Yeah,
and,
but it's already coagulated.
I know, it's
enough.
coagulated. But I do it with SSAs because every once in a while, SSAs can be very stealthy. Okay. All right, now let's close this. So the best way to close this, I find, is you don't have this. It's the DAT clip, which is, it sort of takes clipping to a different level. So normal clipping is 2 prongs, and you just place your prongs and pull them together. Using the DAT clip, which is dual action tissue approximation, you are clipping an edge, but now you hold it and you drag that edge over to the other edge, and then you close the other prong. So you have a post in between. I love that device because this hold and drag technique works very nicely when you're over a fold like you are here.
Are you talking about Mantis clip?
Well, Mantis clip doesn't, the same concept, yes. This is the DAT clip from Microtech.
Oh.
But the Mantis clip is different. The Mantis clip, it doesn't have a post in between.
Oh.
And the Mantis clip, the problem is that, yes, it closes nicely. It has like that sharp Mantis-like hook.
Yes.
But that hook sometimes dislodges, or the other can happen where you can't get it loose again if you want to reposition, right? So there are issues that I have had. I don't want to badmouth it.
This is that clip.
This is not that clip. It's just a regular
just
clip.
a regular clip.
Now, if you use a regular clip, make it vertical, please. I do what's called forklift. So what I do is to make it vertical.
Okay.
So now I'm going to push in, and I'm going to impact here on this edge. And this is where Hiro is going to help me by just kind of slowly pushing the scope. And what I'm trying to do is get this thing, because I hate bridges. You know, I don't like having a bridge in between. So what I'm trying to do is see, is there a way that I can do a water pull and I can bring that opposite edge towards me.
Yeah, by
and
sucking.
by sucking. And I can minimize the bridge. I don't want to have exposed base there in between, you know? So that's the tricky part. That's why I'm not a great fan of using only clips. You can start with you can use clips after you bring the edges together with the DAT. All right, so it's getting there maybe, and I pull a little bit back because my idea is just to hook the mucosa to bring it like a sheet over the base. Okay, start to slowly close, slowly. Come on, start slowly close. Okay, I'm trying to keep closing. And this is where if you had more of a hook effect, it'd be better. There's going to be a little bridge there. Let's try one more time. So let's try one more time. Open. Okay, and now, oh, that's better. Okay, close, please. Does it not close? I know that the Microtech clips sometimes have this problem that, okay, deploy.
So bridge,
It's
what
deployed?
what do you mean bridge?
Is this a Microtech? What clip is this?
This is the sure clip.
Short clip, yeah. So the
Microtech.
Locato is better?
Last 5 minutes.
Yeah. So we're basically, well, let's
Okay.
put the gas on now.
Can-
Put the gas on.
Can you hear me?
Yeah.
Yeah, I have questions about what's the indication size, maximum size of underwater EMR.
I have gotten lesions
depends
5
on the-
centimeter. It's all a question of how well it floats up. That's all.
But 5
And-
centimeter
Yeah.
end lock?
Yes, on block.
En
Oh,
block,
many times.
really?
Oh, many times. Yes.
Really?
I can get nearly all my lesions out on block now. And it takes patience, but you saw everything we do takes patience.
Yes.
You know, Yukata was. I mean, his patience was just unbelievable. You know, I would have lost my temper a long time ago. I would have said, "Oh, forget this." You have to be so patient with. With ESD in the colon, because it wobbles around. Even now, it's wobbling around on me. So underwater, I can kind of, if you could hold that, I'm
Yes,
going
I
to
hold.
try to see, try
Okay.
to close now, see.
And
It's a little blind,
could you
close,
teach me about the condition of generator?
Close. Generator? Yes.
Yeah, condition of generator. Could you
Yeah,
tell
go
me
ahead
again?
deploy, yeah.
You mean the setting?
Yeah,
Settings,
setting.
yeah.
The
Put the gas on.
AutoCAD 1.5. Effect 1.5, AutoCAD.
Okay, there's
In many
Another
in any case,
tiny, polyp?
you can perform the same condition.
So
setting.
now I took off the near focus, by the way, right? Because I'm using gas. So now, if I use near focus, I can't see, it's fuzzy. So out of focus. So now I take the near focus off. So where's that other polyp you said? There's a little polyp. Where was it? Chisai polyp wa doko desu ka?
You can speak Japanese.
A few
Or
words.
you can speak Japanese.
Skoshi.
Yeah, Ken's mother is a Japanese.
Huh? Oral side.
oral.
Oh, upstream. Okay. Sigmoid. Okay. So we'll start coming back. Look, so we're done with
don't
this.
forget
I
your
just have to
specimen.
get the specimen, all right? So I grab the specimen, and we're going to pin it, and we're going to ask our pathologist to tell us if, what I'll do is grab it with the snare, please, because as I pull out, I like to inspect. If I suck it up against the tip of the scope, you can do it with the cap, right? You suck it against the cap, but then you don't see anything.
Right.
So I'll use the snare to just grab it. That was my collateral injury there. So sometimes that happens, but don't worry. I mean, it's just you grabbed another fold that was further upstream.
Yeah, as long as underwater, it doesn't go further than submucosa, right?
It won't. It won't because
won't.
the muscular propria
Yes.
stays round.
Yes.
It's like a leap of faith. There's some things you have to have faith in, right? That
Yes.
the sun's going to rise tomorrow morning, right? There's no proof of that, but you take faith. You have faith. Underwater, you're not going to perforate, but you have to have these little, checks to see how it's reacting, that it floats very nicely. Open. Okay. And if it does perforate, just close it. Our clips are so amazing now today. And if you're underwater, it's really safe.
Okay,
Yes.
Ken, thank you for
Open a little bit
excellent
more, please.
presentation, live
Close a little bit.
demonstration. we have to move to another room.
Close, close, close. Okay, thank you. All right, I'm coming out so I can look on my way out like this.
Thank you.
Good. Thank you, thank you.